we'll also have some education in this. So, talking about insulin, it's always good to talk about insulin now, the product which has revolutionized the management of diabetes, which has been in the world for past 2.5 years, and it's undergone a revolution. It's still undergoing a revolution. And to take this revolution and the signs of insulin, how you're going to get, we have a very good speaker. We are from the same organization, in the sense we've been educated in the same system. Dr. Arun Singh, who's traveled from Bombay to Delhi to Cmes, and he's a very good speaker. We've done a lot of conferences together, and he's going to dwell on this topic of using pre-mixed insulin to match the patient's needs. So we get into the signs of diabetes, signs of insulin, and how do you get a case-based approach in this. I would request Dr. Arun to please start with this talk.
Very good evening. Very good evening, everyone, and it's nice meeting you here again. So I was telling Dr. Ahluwalia sir that so he knows many of you and many of you knows him, but then as a group how much energy you all have and how much warm host you are, and very kind people. So I must say, Dr. Ahluwalia, my DM qualification was recertified with some senior, very experienced clinicians here a couple of years back. So they asked me very tough questions, and then they agreed, okay, you deserve DM endocrinology. So this time I have been given a little easier, simpler topic actually. Now they have some trust. But there's trick also, na. जब आप easy रहता है case तो मुश्किल भी हो जाता है, then you can ask anything. So it's a very simple topic actually, but then let's see if we can generate some meaningful discussion at the end. As Dr. Ahluwalia said, insulin is the oldest antidiabetic molecule available. Neither the disease is new, neither the molecule is new, but still we are discussing it to reach some consensus. And the molecule we are discussing is premixed insulin in type 2 diabetes. So as for the patient needs, so itself, the statement itself says every patient with type 2 diabetes is different, all are not same, and all patients have different needs. So nothing is best for each and every patient. Some disclosures. So I'm contracted by Cipla, so opinion is mine, and the slides are Cipla's. So let's see how much we agree on and disagree on. And there's something on who should be attending, so this is for registered medical practitioners only. And this is the structure of my talk. Very simple, 4-5 slides on each topic. The disease burden. So as much I know, many senior physicians here are dealing with diabetes every day. They see a lot number of patients with diabetes and a lot of experts here. So very simple topics. Disease burden, understanding the contribution of fasting PP to HbA1c, glycemic burden and complications. The recommendations on insulin from the RSSDI, and then I will end with a brief case discussion and clinical evidence to guide us to choose the right agent for such kind of patients. So this is just a customary thing to discuss the disease burden. Everybody is aware of the burden of diabetes itself and burden of uncontrolled diabetes also. So it's not only the burden of type 2 diabetes. The more than 100 million Indians have diabetes, and 3/4 of them do not have control. So that is alarming. Figures are alarming, and these various numbers here, different studies. Different studies, number of participants. Just see the first row, HbA1c. in different studies of patients with type 2 diabetes, 8.5, mean HbA1c 8.5, 8.9, 9.2, 9.2, 9.3, 8.2. So best is the 8.2, otherwise 8.5 to 9 is the average HbA1c of our people who have type 2 diabetes. And fasting PP, so fasting somewhere 140 to 200 and PP 200 plus to 300. So that is the average glucose range of our patients with type 2 diabetes, and everybody knows about the importance of insulinization. So this is actually a retrospective study, but then a very simple study and not difficult to believe. Just simply comparing the group of people who, after failing oral anti-diabetic agents, were initiated on insulin, and the group which was not initiated on insulin. Of course, as expected, a larger proportion of patients who were initiated on insulin will achieve HbA1c. So I don't think anybody has doubt on the glycemic efficacy of insulin overall. And then a debate on whether fasting is more important, postprandial is more important, or HbA1c, we should be happy with the HbA1c. So of course HbA1c reflects the both the fasting and PPBG, both are not in range, you can't have a good HbA1c. So all of them are important. And now we have more parameters like glycemic variability and hypoglycemia, they also need to be considered. This is a little older concept, tried, but now we have pentar, the variability and hypoglycemia, that also needs to be kept in mind. Then again, very simple slide, the contribution of fasting glycemia and postprandial glycemia to the HbA1c. So both of them contribute. On the upper side, you see average 18 mg per dl of fasting glucose contributing to 0.25% HbA1c, and average 18 mg per dl PPG contributing to 0.16% HbA1c. So both of them, of course, contribute. We all know. Again, the slide on same concept. From the left side, the HbA1c, to the right side, it increasing on the x-axis horizontal bar. 6.4, 7.9, 8.9, 9.9, 11.3 HbA1c, and the contribution of fasting and postprandial hyperglycemia. So fasting is the lighter shade, and the PPG is the darker shade actually. So at the lower HbA1c, the contribution of more is from the postprandial hyperglycemia. As the HbA1c goes up, the fasting hyperglycemia contributes to more, but people have contradicted this theory. This data is coming from the West, and the Indian studies show that even at the higher HbA1c, there is significant contribution of postprandial hyperglycemia. So postprandial glycemic burden is always a problem in Indian patients across different levels of HbA1c. So we have discussed the burden of hyperglycemia, the contribution and importance of fasting and postprandial glycemia, and we all know type 2 diabetes is progressive disease. With the time there is declining beta cell function, patients fail on oral agents from 1 to 2 and 3, and on an average 50% of patients will need insulin after a decade of type 2 diabetes diagnosis. And then fortunately we have that molecule. But then confusion starts, which insulin, which is the best, which one to choose. So let's discuss that. So these are the RSSDI recommendations for insulin therapy to initiate insulin. So should be considered for patients who fail to achieve the targets on 3 oral agents. So that can be debated now with the availability of oral GLP-1 and SGLT2. I think that concept is relatively older. The 3-step protocol involves initiation. This is very important actually. It's not the initiation. Initiation is not the end, it's the beginning. So it involves initiation, titration and intensification as recommended for the patient needs. And insulin should be considered in patients with symptomatic severe hyperglycemia at any stage. It's not necessary that patients must use 3 and then use DART. Even for newly diagnosed type 2 diabetes patients with symptomatic hyperglycemia, it should be considered. And then on the right side, there are so many options, insulin options there. So these are the list of insulin formulations which can be considered for initiation, like once daily basal insulin. I think that is the most often used for initiation in stable patients at least. Then you have the option of once daily premix or co-formulation and twice daily premix insulin. I think these are the three choices we have. And the choice depends on number of factors such as age, target glycemic goals, clinical profile, glycemic profile, patient preference, risk of hypoglycemia, etc. So we have to keep that in mind. But since the symposium is on the premix insulin, so there is some guidance on choosing the premix versus basal. 3-4 points here, easy to remember and understand. So these are arbitrary numbers, of course. People don't stick to the numbers absolutely. The discussion is of treating clinician. But based on the glycemic profile, these 3 points, the postprandial spike more than 54. So that is based on the normal, the delta between the fasting and postprandial glucose. So if the glycemic excursion is higher, you must consider the prandial insulin. If the fasting glucose to HbA1c ratio is less than 10, so that means the lesser the ratio, because the fasting glucose is in the numerator. So lesser the ratio means the contribution of fasting is less compared to the postprandial. So again, you should be adding prandial insulin in the regimen. And then the beam, the difference between bedtime and AM morning value, more than 55. So these are the suggestions from the experts group to choose prandial, in fact premix insulin over the basal insulin for initiation. And the other points are almost same. They have same message that limited literacy and simple regimen, easy to understand. But I think here if you compare it with the basal bolus, then it goes in if you have premix, but if you are comparing with the basal, then of course basal is much simpler. So depends on what the patient profile is. So simplicity and flexibility should also be there. So the left part is not so clear, but then that is simple thing about the initiation of insulin. You start the lifestyle modification, metformin, the second and third agent, and after that you have to decide the insulin based on patient glycemic profile. And on the right side there is a guidance on the titration of premix insulin. So morning dose will depend on the pre-dinner glucose values, and the evening dose will depend on the fasting glucose values. We all know that because it has 12 hours of action, but unfortunately our patients keep on doing the wrong thing. They keep on increasing the night dose for the evening hyperglycemia and keep on increasing the morning dose for morning hyperglycemia. So last few slides. This is a given case. 64-year-old male, known duration of diabetes 7 years. HbA1c is 8.9, which is close to our average national HbA1c of type 2 diabetes patients. On the right side, weight, BMI, blood pressure, BMI is 25. Glucose values, it's 8.9, it's not 8.7. Fasting 165, BP 2-hour-PP 230, eGFR 75. So we should be calculating eGFR, not rely on the creatinine. Urine ACR 70 mg, so there is albuminuria, and lipid is out of range. LDL 165, triglyceride 250. And family history is significant. Father has coronary artery disease, mother has type 2 diabetes. As usual with all our patients, tends to overeat, inclination for high carb diet. And on the right extreme is a list of medications. The sitagliptin 100 mg daily, glimepiride 4 mg daily, metformin 2000 mg daily. Those are the maximum doses we are using. And then statins and antihypertensives. 7 years of diabetes, HbA1c 8.9, more than 2% than it should be, and is already on the 3 doses of 3 oral agents maximum doses. And then again, patient is compliant with the medications. On the there is footnote, there is history of UTI 6 months back, and of course nobody wants to take insulin multiple times a day. So I think few points here go in favor of the options are open in basal versus premix. This will not be a very strong case for premix. So premix versus basal. So as we discussed, the postprandial excursion. Here it is. fasting was 165, KPG was 230, so 65 actually. So postprandial excursion is 65, the patient is on high carbohydrate carb diet and simple and convenient regimen. I think people will argue here and we can have a good debate that there is not very strong case for Premix insulin. In this case, was it 100 mg or something? But then let's have a few slides on comparing the Premix versus basal. So again, many people will argue how you compare the Premix versus basal. We have different formulations. But when we are talking, both are the options to initiate, then of course these studies must be done and we must have some data on that. Some insights how do different regimens perform. So this is the set of patients, baseline HbA1c 8.7. The left one is the glargine plus metformin versus Listro Premix twice daily plus metformin. Baseline HbA1c 8.7 in both the groups. At the end of study 7.8 in the glargine group, 7.4 in the Premix group. And the HbA1c reduction here with the glargine was 0.9, with the Premix is 1.3. And on the higher side, it is the proportion of patients treated with different regimens achieving different targets. So HbA1c value, fasting blood glucose value. So fasting blood glucose was better with the glargine actually compared to the premixes, but the HbA1c and the post-breakfast, post-dinner values were better with the premix. So very much expected actually. I don't think there is anything which can't be believed here, but of course both are different regimens. So premix is a more intensive regimen than the basal. You expect a better glycemic control. It does not mean the potency of premix is higher than the glargine. Potency, efficacy is same, but then that is the more intensive regimen. And this is on the safety. Overall hypoglycemia on the left side, nocturnal hypoglycemia on the right side. The glargine versus Listro mix. So overall incidence rate was yes higher with the premix as expected, and the P was 0.041. So very much expected. But on the right side, something is interesting. The nocturnal hypoglycemia numerically was more with the glargine than the Listro mix. Little difficult to believe maybe in this study. And that is actually magnified view. The difference between the two graphs is actually absolutely not the same as here it is. The scale is different. You can see here it is 1 decimal and there it is at 0.05 decimal. So that difference is magnified. It's not actually that huge difference. Meta-analysis on premix versus basal on HbA1c. Again, I think unfair comparison because one is more intensive than the other, one is conservative, and of course you get a better HbA1c with the premix compared to the basal most of the times, and that is what's seen in this meta-analysis. So more patients treated with the premix had a higher likelihood of achieving target A1C below 7 compared to those treated with the basal insulin. Back to the case, so somehow the clinician convinced the patient to initiate insulin, and here again there is an interesting move. We'll have a discussion on that, and I'll also ask for your comments, sir. So here, so we are discussing the initiation insulin can be a basal insulin, can be premixed once or twice, and can be co-formulation. So that's all right. But here the premix insulin is initiated in the morning. It was initiated before breakfast. And dose is titrated weekly, and after 4 weeks there is failure to achieve the targets, and then second dose is initiated in the evening, and then after gradual dose titration the patient has better control, and as the patient is put on a combination of basal and prandial insulin, so sulfonylurea was tapered and removed. So I'll ask for your comments later on, and of the experienced clinicians also. If you start premix once a day, do you start in the morning or evening? So that is last slide. So the summary is about a large number of patients with type 2 diabetes in our country do not have good control. Their A1C is out of range. And of course, both fasting and postprandial glycemic burden is important contributor to high HbA1c and the complications. The choice of insulin has to be individualized. It cannot be same for everybody, and there are guidance on choosing the basal versus premix. Definitely premix is more intensive. It covers your post-meal insulin requirements also, so you expect to get a good control, but with the more intensive regimens, we expect a little higher incidence of hypoglycemia also. So that good HbA1c comes at a cost of little higher episodes of hypoglycemia. And not only Indian guidelines, all guidelines I think do keep premix insulin as one of the options to initiate. No disagreement or confusion on that. Treatment with premix insulin is found to be effective and safe for patients to achieve their HbA1c goal. Thank you all.
Very good. Thank you, doctor.
Sir, please come.
Okay. Thank you, Dr. Arun, for a comprehensive initiation of insulin with premixed insulin. See, in India, what happens is it takes about 9 years of duration of diabetes before you start insulin. The average A1C in India to start insulin is about more than 9. The patient is already on 4 drugs. And insulin initiation gets delayed because the patient's reluctance to take an injectable therapy. Second is the physician trying to explain how to take insulin, and that is again the debate, because earlier in the 90s we had only mixed-art or pre-mixed insulin available, then you had the basal insulin coming in, and now you have a combination of insulins which you can start initiate with insulin. So, Dr. Arun has covered up the how to start with pre-mixed insulin, what factors to take. I would ask, as the privilege of the chair, I will ask Dr. Arun, the ratio of fasting to HbA1c ratio, which is something new which is coming. Could you throw some light on it?
Yes, so that is based on the actually calculation of the interpretation of 1% HbA1c to the glucose value. So that is indirect ratio, sir. And the ratio includes the HbA1c in the denominator, that is the bottom of the numerator, upper the value of the fasting hyperglycemia. So higher the ratio means fasting hyperglycemia is the predominant burden to the HbA1c. And as the principle we follow. Fix the fasting first. So there probably that is the suggestion. So these are not very strong or stringent recommendations. They are suggestions to consider resources.
Secondly, in this particular representative case, you started with once a day pre-mixed insulin, not twice a day. So basically, looking at the pharmacokinetics of pre-mixed insulin, most of the insulin action is over by 14 hours. So it's not going to cover up your 24 hours, unlike the basal insulin. Why do you think in this particular case it was started once a day and then shifted to twice a day?
Yes, sir. So disclaimer is opinion is mine, slides are similar, but then let me try. So I generally don't do that, starting the premix in the morning. But I think there is some point in starting the premixes once a day. That is also a okay thing. But then that should be before dinner. Because we have been using NPH also as a basal insulin for a long time, and with the NPH you achieve the fasting normoglycemia, and many times you are able to cover the daytime hyperglycemia with the help of oral insulin applications. Yes, physiologically that does not sound a very rational thing, but morning thing I generally don't do that unless a patient is on steroids, something like prednisolone or for some inflammatory condition. Then the pattern will be fasting normoglycemia and the daytime hyperglycemia. For those situations, I do use morning AM premix insulin. But for otherwise, I think I'll always start, if any case, if I'm going to start OD, of course, ideally it should be easy. But if I start OD, I'll start aiming to get a normal fasting glucose, and if that is able to maintain the daytime normoglycemia, then that's fine, but otherwise patient will need twice daily.
See, the insulin analogs, the Listro was the first analog which came to the Indian market in 1999. And then you had the S part, and then in 2003, 2004, we had the premixed insulin. So initial studies of premixed insulin, there was one Gartner study which said 1, 2, 3. You started once a day, like the premix, and then you shift over to twice a day, and then in rare cases you shift it to 3. The advantage of starting once, you are kind of buying time with the patient. That you start with once, you know once is not going to work, so you buy about 4 to 6 weeks before you shift over to twice a day. Small percentage of patients will not be controlled with twice a day. You may give a third shot, but that is only 5%, and that was a study protocol which was there. After that, you use this basically premix twice a day. The second is when you start using premixed insulin, I'll take your expertise on titration of insulin dose. How do you titrate the morning and evening dose of insulin?
So before that, on thrice daily premixes insulin. Again, I never use that. I know some of the suggestions. You can use thrice a day, but then there is a stacking of insulin daytime.
Mike, please, Mike.
So there is stacking effect of premixes insulin thrice a day. The pharmacokinetics, you all know, 4 hours, 12 hours, 4 hours, 12 hours. So there is a high risk of midnight and early morning hypoglycemia with thrice. So if third injection at all has to be given, I will personally choose the rapid acting or short acting before lunch, not the premix. Coming to the dose adjustment, so again, when you have started on 2 doses, so of course we have to target the fasting normoglycemia, and dose intensification has to be balanced, not too aggressive, not too conservative. Both the situations are not good. Once patient is not getting control, he or she loses the confidence and comes back, it's useless thing, isko leke kuch fayda hi nahi hua, band karo. And if you write a dose which causes hypoglycemia, again patient stops the insulin. So the suggested frequency of intensification is maybe alternatives or twice a week at maximum to a weekly thing. And ideally glucose should be tested before the meals, the AM fasting and the evening. And you have to set a target. Let's see, I do start little conservative. I'll not target 80 to 100 state. I'll target 100 to 130 for most of the patients whom I'm initiating insulin. So set a target 100 to 30 fasting plus minus 10% in the evening. So if both are in the same range, the fasting and the evening same range, that means your day dosing is adequate. If the evening is going higher than the morning or coming lower than the morning, that means your morning dose is either high or low. So that is how I will decide the dose of morning. And of course, the evening dose has to be based on fasting glucose values. And again, you set a target. The suggested approach is to change the doses at least maximum 10 to 20% of the prescribed dose at a single time, twice a week or a weekly. And that is how I do it.
Thank you, Doctor. Thank you, Dr. Arun.
Thank you, sir, for starting the discussion. I would give the platform to Dr. Manish Gupta.
Sir.
Then I will come to Dr. Shubham Vats, DM Gastro, treating a lot of patients of diabetes with gastroenterological disorders. I will give it then to Dr. Podar, then give it to Dr. Anil Gupta, and our oncology friend Dr. Amish Vora. You cannot be standing there. You have so many cases who need insulin. We have discussed. You've been referring so many cases of diabetes to me. Sir, please sit down. I need your feedback. It's going to be an important discussion to Dr. Manish Gupta, who actually is our colleague, along with patron of the forum, Dr. S.K. Mathur, president of the forum, Dr. P.K. Gupta, myself, Dr. Chandrasekhar, general secretary of the forum. We were students of Dr. Ahluwalia, and we did a certificate course in diabetology, sponsored by PHFI and Dr. Mohan's Diabetes Education Academy. Our youngest tycoon.
Member.
Sir, I think sir has a comment to make before.
Doctor, no, you make a comment. We'll ask for sir's comment in the end.
Sir.
The boss,
Sir, it's
the
the
boss,
reverse
the boss always has
we
the
weren't
final
trained like
word.
that in medical school.
The boss always has the final word.
Sir, always.
You go ahead and.
Sir, one comment and one question. So, sir asked that starting premix at the pre-breakfast, my take would be only with the first phase insulin defect. And India being more carb loving country, we see maximum post-breakfast spike, the maximum even with the maximum data with the CGMs. So maybe that would be a thought process that maybe versus basal, if you first just fix fasting, you're still left with the PP surge. That's one point. Second point, sir, once the glucotoxicity is knocked off, would that help us in some way convincing the patients? That's my question.
Yes, so I agree with your comment actually. So many times patients do good fasting glucose, but then the daytime is always high, post-meal is always high, and then you have the choice of either prandial or premix that will cover the entire day. So I absolutely agree with that. Coming to the C-peptide, so I'm not doing that very often, very rarely I must say, and that is the only situation when patients are not willing to take it actually. So I remember just one case last month. Report करा के दे दो भैया कुछ नहीं हो सकता है आपका. So that is the only situation, but it doesn't have a clinical utility in general because poor response to oral agent itself tells you there is nothing left. There is nothing left. So I think only role is in convincing the patient, and if you have really confusion regarding the type of insulin, there is not so clear cut case.
On this very concept, the earlier concept was once you land up in beta cell exhaustion, they can't come back. But there was a concept which came into being that there is beta cell dominancy once there is glucotoxicity, and some of them come back. So that was the point where...
Yeah, so yes, recovery. So that happens naturally. You start patient on insulin, he is on 3 and 4 oral agents, and after a month or 2 months, patient comes back and tells you, Doctor Sahab, insulin to बंद कर दिया है और sugar बिल्कुल ठीक चल रही है. So the situation itself tells that the beta cell has come out of glucotoxicity and the orals are working. So generally, when it's working, actually you will not need to do it. When it's not working and patient is not willing, then you will need to C-peptide.
Let's put it this way. See, you have to decide when you look at the patient whether the patient is more insulin resistant or more insulin obedient. Somebody who's got thin body weight, who's got low, who's younger, who's got rapid progression of A1C, this patient is likely to be insulin obedient. So you start with insulin. In such patient, you want to convince whether he is type 1.5 or LADA, or you may do a C-peptide just to convince that insulin ही चलेगा और कुछ नहीं चलेगा. The other type of patients who come with hyperglycemia and glucose toxicity, once you take care of glucose toxicity, the concept that एक बार insulin शुरू हो गई ये बंद नहीं होगी, that's kind of, you tell them this is a temporary measure. We control your glucose, get them in range, and after that we reassess whether you actually require insulin or not. In that situation also, for your academic purposes, you find the glucose under control, the beta cells have started recovering, you will get a good C-peptide. But overall, again, it comes down to standardization of C-peptide. We are not doing it routinely, and I don't know, most of the labs don't consider standardized. And secondly, if you have to do C-peptide, you actually do a glucagon stimulated C-peptide to know whether it's there or not. So this is cumbersome. It's more of academics and trying to prove that I'm doing some tests that the other person is not.
Sir, I would request a comment from Dr. Shubham Vats, Director of Gastroenterology at Fortis. He is a great user of insulins. Your comment on Dr. Arun Singh's talk.
First of all, I know Arun Singh since my MD days at MMC. He is my senior and we work together. And I remember he came back from Singapore. I didn't know. We met on the first time we went to Faridabad. We met on the flyover. Both of us had been given overspeeding challans. He would have So that is when I said you're back from Singapore, and he said, "यार भी चलान भरते और चलते बाद में बात करते." I think after that, sir, after that I sent you enough patience to tell you my presence here. So very nice to see you. I didn't know it's your talk actually. I was so busy. But sir, just talking about metabolic side of gastroenterology and endocrinology, my only question would be that since it is actually starts with insulin resistance, metabolic syndrome, fatty liver, then fat coming out of the liver into the blood, then it depositing into your what you call coronaries, hypertension, and into your cerebral circulation, strokes, MI, and everything. So insulin is known for weight gain. So I am considered with, and I have been in the process of reversing my insulin resistance. So the only question I have is that is there a downside of long-term insulin use, any kind, with weight gain? and increased atherosclerosis or increased risk of high insulin, what do you call? So hyperinsulinemia induced, so insulin resistance. I'm just talking about the pathophysiology. So is there any data or in your experience increased cardiovascular complications with use of insulin?
I think I would just subtitle it, especially after the great remarkable achievements of SGLT inhibitors in terms of bridging the macro and the microvascular gap. So you comment on that.
Question is very relevant, sir, actually. So, on the one side, the hyperinsulinemia in non-diabetic patients, otherwise, we link the insulin with all the inflammation. So, it has multiple receptors and multiple pathways, cellular pathways, the anabolic pathway, metabolic pathway, and it has a role in creating inflammation and atherosclerosis. But in patients, those who have insulin, so you are starting it in actually insulin deficient patients most of the time. Those patients who are having a good endogenous insulin level resistant, as the sir said. So now there's a newer concept of classifying the patients insulin deficient, resistant, moderately insulin deficient, the mixture of two. So for the very highly insulin resistant patients who already have high endogenous insulin will not be a good choice as GLP-2, GLP-1 are the molecules and the weight loss, maybe metabolic surgery will be the best thing to do. Because the answer is on the exogenous insulin uses. So usually you will not achieve those high levels of insulin. You see 250 units per ml with the endogenous, severe glycosis, nigricant, severe obesity. That is the theory I am talking about. Of course, we don't have any high quality data on that. The uses, the dose of insulin and the cardiovascular outcomes. I am aware of the origin trial which studied the glargine in high risk CVO patients, and it was found to be safe. But of course, it does not have those aids, as Dr. Chauhan mentioned, the metabolic benefits, the cardiovascular outcomes. Any comments from Ahluwalia?
So your question of insulin causing atherosclerosis is true in the sense, in the 70s there was a belief that if you give insulin, you're going to, because insulin is an atherogenic molecule and it can be. So there was a study, small studies of about few hundred patients of University Diabetes Glucose Program. It was published in 79 or 81, where they showed that in this study, those patients who were on insulin got higher atherosclerotic cardiovascular. So that kind of created a query that insulin will cause. Then you followed by a UK PDS, which was the largest study over 16 years, which proved that insulin giving did not increase the risk of atherosclerosis. In fact, insulin reduced the A1C and decreased the risk of atherosclerosis. Followed that, you started using insulin as a preventive data. As prevention in origin trial with glargine, it did increase. It did not benefit, but it did not increase. So 3-point MACE was neutral, it was non-inferior. Followed by a DEVOTE trial, which was on degludec, which showed that giving insulin improved the cardiovascular outcomes, but did not really increase. So the superiority was not proved. So this concept that insulin will produce atherosclerosis. The crux is hyperglycemia. So if you have hyperglycemia, you'll have the cytokines, you'll have reactive oxygen species, you have glycation of proteins, and these will ultimately result in tissue damage. So what insulin is doing is just correcting your hyperglycemic abnormality and restoring your the biorhythms or restoring your cellular milieu, which is good. So that concept that giving insulin will increase complication is down and dusted.
Fortunately, sir, our patients' insulin doses are not that of the Americans, which they have 500 IU strength because
even in America, the study was done in America only, which found that even giving insulin does not. But this was the time when we didn't have so much of drugs. Now you have GLP-1s when your patient is obese, obviously it's anti-atherogenic. You always start with SGLT2. And the assessment for cardiovascular risk starts right at the beginning. So you don't look at the patient at hyperglycemia, you look at whether the patient has got cardiovascular disease, you look at the patient who's got renal disease, the patient has got other complications, patient has got obesity. Then you choose the type of drug, and if it doesn't happen, at step 3 comes basal insulin. Because the insulin is started with the A1C below 8.5 in the West. In our case, we start insulin at 9.7. So that makes a difference, the number of time duration also. So our population, because of the particular, it's out-of-pocket expenses, the patient has to take the titration. So giving insulin is not easy, it requires your extra time, it requires patient's time. So most of the time you try and pass off with another agent and then move it.
Dr. S.K. Poddar, sir.
Sir, recently I came across a study which concluded that 2 hours postprandial glucose is better predictor of coronary artery events than HbA1c. Is it true? It was a study in
Postprandial glucose is a better predictor
of coronary artery event, cardiac events in
cardiac event than HbA1c.
So that will be a kind to similar situation like impaired glucose tolerance also. Where the postprandial glucose is high, HbA1c is normal. I think that is a lot of situation. And the fluctuations, the glycemic variability, I was talking of glycemic pentad, that was tried fasting PP, HbA1c, the pentad includes the glycemic variability. So higher glycemic excursion means high glycemic variability. I believe that can be the reason of contributing to the excess metabolic distress and inflammation and atherosclerosis. I'm not particularly aware of this study.
Yes, in this study, I've also read this study offhand, I will remember. The higher PPG values means higher amount of glucose excretion. Higher glucose hitting the endothelium, more endothelial dysfunction. And endothelial dysfunction is the precursor for coronary or macrovascular and microvascular damage. So it's basically you try not only cover the fasting, but you want to cut down the postprandial spikes. That is why the importance of glycemic variability and cutting down the spikes become important.
So in patients of diabetes, we should not depend only on HbA1c. We should also do fasting or PP glucose frequently.
See, HbA1c gives you a summated value over 3 months. So you have to know point of care testing, that is with the glucometer. But even if you find the patient is getting highs and lows, so in that case, you should use a CGMS where you find the variability more. Then in type 2 diabetics also, you should use a CGMS once in 2 months. In type 1 diabetics, you would like to use it much more often because that helps you in getting the amount of variability, correcting the dose, response to the carbohydrate load, amount of glucose. So management is just not HbA1c and glucose, it's shifted to variability, it's also shifted to the durability and sustainability of a particular drug.
I would request Dr. Bhaskar Shukla to ask a question. Dr. Bhaskar Shukla is DM Neuro. Naresh. He is a senior neurologist at PSRI Hospital. And we have Dr. Amitabh Gupta, who is a senior neurosurgeon at PSRI. Great team at PSRI. Let's clap for them, yeah. They are here. They are here to hear a talk on insulin. We are very, very proud of you. To please come here and to honor your commitment. Your question.
So wonderful talk, sir. Sir, especially I know, sir, Dr. Ahluwalia, we were in Columbia Asia at the time. It used to be Columbia Asia.
As
Sir, I don't remember. Do you remember, sir?
As colleagues.
Apurva kithe ko pe?
Very good. Great.
Sir, my question is, I'm a neurologist, so I see neuropathy cases very often. And the diabetes is, of course, the most common cause of neuropathy in our country. There is no doubt about it. It is said that when the diabetes is poorly controlled or not well controlled or so uncontrolled, so it leads to diabetic neuropathy, especially if it is long-standing. But in my practice, I have seen, even in those patients who are in the pre-diabetic range, the neuropathy is still there, and sometimes they do land up in severe neuropathy. We do the nerve conduction studies, they turn out to be normal, and the patient is complaining of severe burning dysesthesia, cannot sleep through the night, etc. So probably small fiber neuropathy is there. So how often do you see, sir, like in pre-diabetes,
Even in
what is your experience?
do you encounter neuropathy?
It's very well documented.
Yes, sir.
This phenomena is very well documented, just as the case Dr. Podar said, and even IGT has a higher cardiovascular events, and even in pre-diabetic population, I think there are studies which have shown not very high, but maybe 10% of the cases may have diabetic neuropathy. I think that is the most common microvascular complication of hyperglycemia, and well documented that pre-diabetic patients do have symptoms, and you know the positive symptoms will be accompanied by normal NCV.
Yes, sir, what is your experience like this molecule, epalnistat? So often use it, but
yeah, I
I'm
think
really not very convinced.
I think you people use much more often. The neurologists use much more often than the endocrinologists. I don't use much often. I don't know about Dr. Ahluwalia, but I think as a group of endocrinologists, we use very less often. But at times you are exhausted and there is distressing symptom. You try all cocktail actually for many patients. Patient is not able to sleep and symptom is just not going. You give highest dose of all available recommended molecules. It has low level of recommendation in ADA and all the societies of diabetes. It was supposed to be very wonderful molecule based on that understanding of protein kinase C and all those, but then because there are multiple pathways involved, so targeting one pathway will not help as expected. As in the case of hyperglycemia, because there is octet, so targeting one pathogenesis will not give you enough relief. The experience is limited, but I will say even the result is not very great.
Can I just for a brief moment? Whose car is 9541? MG. Morris Garages. Whose car is 9541? 9541. कार का चलान है किसी की गाड़ी अपनी? It's creating lot of issues. So ठीक है, that is fine.
My question is just simple. The continuous monitoring sensor we use currently, and the reason why I'm asking is that you can modify your lifestyle, which I think is the most important reason for using that sensor. Though you can use that sensor in patients where there is absolute problem, because one of my dear uncle Mamaji has that complete pancreatectomy. So his erratic glucose level, so he has to use it. You never know when it goes down and it goes up, so it is very erratic. But in general, which I believe, which sensor do you recommend, like in case of continuous glucose monitoring, you can use, especially for the doctors, because we have a high stress value. Most of the doctors are, I think, most of them are in pre-diabetic range because of the lifestyle factors.
Which CGM of choice?
Absolutely agree. This is good for brittle diabetes. I think we don't have any options there. So I have used Medtronic and this Abbott Librephy style, and it has two versions. The latest one gives you a real data, and the other one is the hidden one.
There are more players now coming.
More players coming. Yes, yes. So that will be good actually. That will be good for market. But I think as of now, the Librephy style is the only thing which is freely available, and everybody is using that. Fortunately, its accuracy has improved. Its accuracy has improved. The earlier version did not have good accuracy, and it used to show false low readings.
So why I'm saying that, I tried that Lily one, and it showed a, I don't know, is it fair enough to infer in 15 days it can show you HB1AC levels and it can show you...
They are not reliable.
So HbA1c, it's a guess HbA1c, it's not actually HbA1c, it estimates HbA1c. If you maintain those values for 2 weeks, for next 3 months, then you may get that HbA1c. Your actual HbA1c has not come down. So it gives estimated HbA1c. For example, HbA1c was 10%. You put a CGM. Now your glucose values are perfect, all in range. So it will give HbA1c, estimated HbA1c of 6.5 or 7. Your actual has not come down. It is giving you estimate that if you maintain these values for next 3 months, you will get result.
So fair enough to say that you can try to manage your lifestyle by looking at your glucose level and activities and food habits.
It's good guide. Yes. So when used by the knowledgeable people, it's good.
You don't require a CTMS to tell you what your lifestyle.
We have a word from Dr. Arun Gupta sir, our 71-year-old young diabetologist, one of the oldest MD medicines here. Sir, your comments. It will be very useful to all of us.
In the premix, how often you use Nizodite? Because I use it quite often, that helps me quite a lot. Because it's ultra long acting and it fixes the fasting as well as it fixes one of the post breaker. And suppose it is not getting controlled, I add another short acting insulin at another time.
We are at a forum sponsored by Singh.
Sir, it doesn't fit in the picture. We might as well discuss it during intermission. Just a minute. Dr. Jitendra Saxena.
Sir, my question is, as physician, one of the most challenging part is when we are advising patient insulin is the hypoglycemia. And most often many of our patients use CGM. Now, do you see any role of artificial intelligence where we can, based on the algorithms, can we develop such machines that they can alarm the patient beforehand that there is a possibility that you can go into hypoglycemia. So it helps our patient. So do you see such a possibility? Do you see the role of artificial intelligence? And is it something which is coming in future?
It's already there. I think it's already there. One is the sensor augmented pump therapy, where the pumps are connected to the sensors and they are communicating to each other. So not even just before actual hypoglycemia, you get alert, and when the patients are on insulin pump is suspended. So it's already there, and even these versions of CGM, they do have those values at least. So they don't predict, but you can set the safe range, even this Libre style. So you can set the hypoglycemia alert value and connect it to your phone. So it's already there. Right?
Natural intelligence. See, the technology which you get in India is almost 10 years old, right? So second, what you're looking at, when you talk about artificial intelligence. Artificial intelligence is nothing, it's just submitting the data which is going to be worked. That data, the larger the data set you have, better is the ANN, artificial neural network, or the machine learning tools which you can apply onto the data. To that effect, now we are getting into advanced technologies. The first advanced technology is going to be, it's already there in the US, is the insulin pens which you use. We are using pens which are basically of the early 2000s vintage, because the pens are expensive. Now the pens are going to come with the sensor. It has an audio and alarm. It tells you the amount of dose which is being actually injected. It also gives you a reading amount of dose which is remaining. And then the advancement of this will be on calculation of the next dose which will come, which will be feeding in the glucose values. That is going to come, it's already there in the West. Second, talking about artificial intelligence, now the closed loop system, which is the Medtronic pump, which is already in the US, it's not in the Indian market. Now what it does is, it's a closed loop. You have a sensor communicating with the pump, and you feed in the sensor values, you feed in the carbohydrate counting, you feed in the insulin. Now based upon this, it does an algorithm. And this algorithm, it will calculate the 3 days of insulin dose, which is going to come in the form of basal or bolus insulin, and the type of insulin that's fed, that this is what you're going to eat over a period of time. After 3 days, based upon the values, it recalculates the algorithm. So it's there, it's not that it's not there, it's already there. It's not in the Indian market because it's, and as and when you have more data, the AI depends upon the data, because if you have larger data set, that will get into a better ANN and a better machine learning outcome of that particular thing. Third is, you already have the diabetic retinopathy calculation using AI. So what the initial tool which came was just on about 2000 pictures of fundus, and based upon that you could predict. So this whole scenario by 2030 is going to change drastically. Whether you and me would be practicing or you'll be just practicing AI, that only time will tell.
Dr. Amish Vora, sir.
Thank you so much. Since you mentioned about 2030, today only I was reading an article about 2031, and which are the sectors which are going to make 7 trillion economy for India, and healthcare was one of them. My question, I'm a medical oncologist. My question basically are two. one, I had seen one patient of euglycemic diabetic ketoacidosis. And this was diagnosed by my endocrinology colleague. I missed that diagnosis. So I would like to know from you how many of you glycemic decay, which is very common in oncology. When I read about it, I realized it was common. Second thing is about the premixed insulin. In a chemotherapy patient, we give steroids very frequently. And no premixed insulin. I have burnt my fingers with all premixed insulin because the glycemic index is so erratic. The only thing which works is simple human insulin, sliding scale, maintain the glucose between 150 to 200 and nothing happens. Your comment, sir. Any one of you, sir.
Let Arun speak. I'll keep brief. I think euglycemic decay as such is not very common in India, but must be commoner in oncology setup than other groups because of poor oral intake.
How do you diagnose?
Poor. So symptoms of decay. Any sick patient with diabetes, you always have to consider decay, poor appetite, nausea, vomiting, dehydration. So decay is always a differential there. Pain abdomen. So symptoms will be same, but you will be misled by normal glucose values because you are looking for hyperglycemia as per diagnostic criteria. Sugar should be more than 250 and 300, and it's normal, so you are not thinking. I see daily these patients of the euglycemic decay even in my CCU cardiology unit, heart failure. They have heart failure. They have impaired renal function, not eating well. They are insulin deficient, so they are missing insulin, not eating, and insulin deficiency is landing up into ketosis. So that must be much commoner in oncology and other patients who have debilitating disease and poor oral intake. The second question was on premix insulin. So actually the hyperglycemia caused by steroids is dependent on their pharmacokinetics. So whether it's short acting, it's hydrocortisone, or intermediate acting prednisolone, or long acting dexamethasone. So we always look which steroid the patient is taking, and we have to match it with the similar insulin formulation with the similar pharmacokinetics. Actually, fortunately we have, and there is a study from our own Gangaram hospital, actually by endocrinology department, by one of my friends who was doing DNB there. So we tried to match the steroid-induced hyperglycemia, where the molecules were different based on their half-life, hydrocortisone, prednisolone, methylprednisolone, and dexamethasone. So that has to be matched with the insulin of same duration.
Sorry sir, I'm taking just one minute. My problem is I have gone through all that. I'm practicing for last 20 years. Dexamethasone is the common steroid we use as a pre-medication. We know the half-life of dexamethasone. But the moment the half-life of dexamethasone disappears, the chemotherapy-induced loss of appetite increases. And from hyperglycemia, you get hypoglycemia. I can't tell you number of patients at 5 a.m. in the morning with 31 of steroids I have seen. 31 of sugar I have seen.
I agree.
I want to ask you, how do I manage it apart from just sliding scale, plain insulin? Please guide me on that.
See, I would say, doctor, why don't you involve an endocrinologist in this matter? So you solve your headache also.
I do not treat hyper. Sir, I do not treat diabetes. I do not treat diabetes. I call only endocrinologist, and the final solution was only sliding scale, plain insulin.
So it's
non-expert.
Let's get down to steroid-induced hyperglycemia. COVID has taught us all about this steroid-induced hyperglycemia in one, right? And taught us more which we are thinking only in theory. Second is first question about euglycemic ketoacidosis. By definition, euglycemic ketoacidosis is when the glucose is below 250, your pH is acidotic, and urine ketones are positive. So that means euglycemic, which depends upon either the patient is on drugs like SGLT2, or the second is patient is not taking enough oral feeds, or second is the patient is on steroids or certain anti-malignancy compounds. When I was in Army Hospital, 5FU used to give a lot of hyperglycemia and ketoacidosis. Premix is not to be used. No premix in oncology, or not premix in, it has to be short-acting insulin and has to be short-acting insulin analogs. To counter the hyperglycemia, please give a 30% or 20% dose, expected dose of basal insulin in the morning. You have long-acting second-generation basal insulins available. And Classical, if you check, the hyperglycemia generally happens between 2 to 5 if you're given morning steroids. So basically, you increase the number of injections or short-acting insulin analogs, not insulin, and give an additional shot at about 3-4 o'clock. You will prevent the peak which happens at about 5 to 6. And this has been taught to us by COVID, where you are monitoring the sugars, the glucose about 4 times, and then deciding upon. The first day assessment will give you what is the therapy is going to be. So that's the reason I said, please get a colleague, endocrinology, who's going to help you with this.
Dr. Achal Kantur, sir.
Sir, when we are when a patient of type 2 diabetes on 3 or 4 oral anti-diabetic drugs, then when we want to initiate insulin therapy to him, we start and which drugs we have to skip away, because metformin can easily keep. Should we keep the DP4 inhibitors? I think this glimepiride and sulfonylurea we should avoid it. Number 2 is that there is one more case, sir. In some cases I have learned that if we are giving basal bolus, then if we have to start premix, we have to reduce it by 50% of the dose. What is the logic behind it?
So the
there are
question
two
is,
things I want to
yes, let me clarify the question, sir, for the audience. If patient is on multiple medications, oral medications, and we start the patient on premix insulin, patient is essentially on DPP4 inhibitors and glimepiride. What do you do to the existing dose of DPP4 inhibitor, and what do you do to the dose of glimepiride? Do you go by the classical hypothesis that you reduce the dose of oral sulfonylureas by half when you start pre-insulin premixes? What do you do, sir? What do you do?
Yes, sir. So the two situations. So patient is already on sulfonylurea having maximum doses. Patients are on maximum doses when you are planning to start insulin, and there is clear-cut suggestion on the initiation dose, sir. So depending on you are starting basal insulin or premix insulin, basal is the more conservative. So insulin sensitive, insulin resistant patient, that will also play a role. Weight of the patient, severity of hyperglycemia will also play a role. So keep it simple. If you are starting basal, you can start with 0.1 to 0.2 unit per kg body weight. 0.1 will be very low, but for sensitive patients, a very lean patient with the renal dysfunction, even 0.1 will be okay. For usual type 2 diabetes patients who are overweight, obese, 0.2, 0.3 unit per kg would be a good choice to initiate basal insulin. But if you are initiating premix insulin twice a day, that is more aggressive, and the dose requirement will be higher here. So here you will go on an average 0.4, 0.5 units. So dose will be double because you are giving 2 doses, 0.4, 0.5 units per kg body weight, and then divide that into 2 doses. Conventional teaching, which I was taught, 2/3 dose in the morning, 1/3 in the evening, because you need more in the morning. Patient is eating to cover the lunch also. And not with the basal, but with the premix insulin, be careful with the doses of SUs. That should be reduced by 50%, but not with the basal only. So, you want to add something?
Sir, can I ask one question?
Dr. Sajid, we'll give you 2 questions. No, they ask you 2 questions, and then we'll go to Dr. Tulsi and Dr. ML Kalra. I kindly give me just 10 more minutes. We are going to give you dinner at 10:15. Whatever the status of question answer session, but all of you would agree it doesn't look nice when there are 30 people here having dinner and we are having question answer session of the caliber of, a moderator of caliber of Professor Abhay Ahluwalia. I think let us give them थोड़ी सी इज्जत दो यार, प्लीज मेरी रिक्वेस्ट है आपसे. अगर आपको कुछ चाहिए तो मैं टेबल पे भिजवा देता हूँ, लेकिन 10 मिनट वेट कर लो प्लीज. I know there is lot of pressure on Deven and Naresh, but give us 10 minutes please. I request all of you. Sir, please.
Sir, very short 2 questions, very basic. I'm a general practitioner. So I face a problem of starting premix insulin. Like said, you said the morning dose, hypoglycemia should be avoided, and morning sugar should be controlled first. Now I start with the night dose. How do I go for 2/3, in the morning and 1/3 in the evening? How do I reach that? When I'm starting at the night. So how do I go to 2/3 in the morning and 1/3 at night? Because I'm starting at the night.
You agree with that hypothesis first of all?
Number two, sir, if somebody has hypoglycemia in the afternoon because of missing lunch or higher activity, he comes back to me in the evening with blood sugar of 79. What do I recommend in the evening for the evening dose? Is there any algorithm, any formula for that? Because I fail to understand now what. Do I reduce 4 units, or do I omit, or do I reduce by half? What do I do? That is a basic question, sir, that I face.
So to start with I think you want to start, you are saying you start once a day. So of course there is no point here 2/3, 1/3 when you are giving just one dose.
When I freeze it, sir.
So that is not very common practice, but I think that can be done premix before dinner. But of course then there will be no calculation as 2/3, 1/3, and when you are giving one dose daily, then the dose will be 0.1 to 0.2 unit per kg body weight. You start with that for 60 kg. For very sensitive patient, even 6-8 units is fine. For usual patient, 10-12 units will be fine. You have achieved the target fasting glucose values, but the daytime is high, pre-lunch is high, evening is high. Of course, you will need to add the morning dose to control the daytime glucose. I think that is how I answer the first part. Second part.
One moment. So now if I am giving 12 at night and 4 in the morning, it is sufficient for me. So do I still need to switch it to more in the morning and less in the evening?
So that is interesting situation. Actually, this is situation again to the similar to previous situation, the sliding scale insulin. What mistake we are doing here? We are giving the correction dose in sliding scale. The pre-dinner is high, so you are giving higher dose in the evening to bring the fasting down. If you control your pre-dinner, if you have a normal pre-dinner glucose value, you will not need to give that high dose in the dinner, I think. So you are switching to two. I'll give a little higher dose in the morning and reduce the night dose. Actually, I'll do that. And the same situation happens with the steroid-induced hyperglycemia with the Medrol or the this thing. Your 3, 5, 6 p.m. is the highest. Pre-dinner is 400, and the post-dinner comes automatically without giving anything. It comes to 200, and you end up giving a high dose of regular acting insulin, highest dose before dinner, and the glucose is itself going to fall down, and the patient develops hypoglycemia in the morning. So night dose should be reduced. You need to target the pre-meal actually rather than post-meal. Post-meal itself will come down. That is the concept we follow. Fix the fasting first. So it's like fasting in the evening. And the second part is the evening glucose is low towards the hypoglycemia alert value. So that situation is with the 2 doses or 1 dose?
2 doses.
2 doses. 2 doses. 2 doses. I think it needs a little discussion. So 70 is not a actual hypoglycemia, even it's alert value. Definitely you need to cut down the next morning dose, no doubts on that. Next morning dose. And
not the night dose.
But evening, so one is the treatment, one is the prevention. So let me simplify, try to simplify. One is the treatment of hypoglycemia, one is the prevention of hypoglycemia. So when it is actually there or it's imminent, you expect a hypoglycemia, of course it will be a wise decision to take a little lower dose that time. I'll teach the patient to take maybe 2/3 of the advised dose. When it is 70, 80 is towards the lower side of target, take the 2/3 of the dose, don't miss, because you miss, it goes 300 and again patient takes higher dose, next day that cycle continues. It's low, he doesn't take, then it goes high, takes extra dose and that continues. So I'll suggest to reduce the dose by 20-30% at that time. And the next step is to reduce the morning dose so that you don't have the hypoglycemia next evening, and then resume your pre-evening dose next day onwards.
Dr. Tulsi sir, you have 5 minutes and Dr. Kalra has 7 minutes, 2 minutes, total 7 minutes. And we are going to wind it up.
So let me compliment on those wonderful talks by Dr. Arun Singh and Dr. Ahluwalia. I have my and some wonderful questions from our colleagues. So to address, Dr. Amish has left. Okay. Anyway, so to address his question, Dr. Ahluwalia rightly said, EDK is just like DK, except that probably, the glucose is less than 200 milligrams, and patients typically are on SGLT2 inhibitors, and steroids or anti-malignancy drugs as he would prescribe. So treatment remains the same, give IV fluids like normal saline and give insulin. So that was as far as his question was concerned, and Dr. Ahluwalia already talked about that. So Dr. Arun Singh, talk us about the newer insulin analogs like Listro, Aspart and Glulising. Are they preferred in specific comorbidities like CLD and CKDs? Tell us, sir.
What is the specific role of analogs?
Yes, sir, actually, so you are right, and I mentioned it in the beginning of my talk, that saying the 1 unit of X insulin being inferior or superior to the Y unit of X unit of other insulin is not fair in terms of efficacy at least. So all insulin have similar efficacy in bringing down the glucose levels. So glycemic effect is same, 1 unit to 1 unit of each insulin. Is all the difference in their pharmacokinetics, the onset of action, the peak action and the waning of action. And that is the advantage we take in our clinical practice, depending on patient's glycemic profile. So overall, the analogs, the newer analogs, even now the rapid acting analogs, we have the rapid Lispro, rapid acting Aspart. So the only advantage is their onset of action is more closer to the physiologic endogenous insulin secretion. You get the, normally when you eat, so you immediately get the first phase of insulin secretion, so there is no delay physiological. But when you have been using regular insulin, there is delay in the onset of action. So you are absolutely right, they are definitely preferred in special situations. Of course, there is no recommendation that they should or must replace the older generation regular human insulin. Efficacy wise they are same, but it's the safety and the convenience which has some edge with the newer analogs. The rapid onset of action, those patients who have poor oral intake or at the risk of hypoglycemia like CLD as you said, or advanced CKD, acutely medically sick patients also. At times you don't know whether the patient is going to eat or not. The patient is in IPD or even discharged from OPD. The patient is not sure whether he or she will eat or not, and even after eating whether she or he is going to digest it or not, will vomit or something. So analogs do have advantage. You can give them immediately after meal also. That is, I think, the advantage here.
So apart from when you could give immediately or before meals or immediately after meals, do they have some other advantages like less weight gain, less hypoglycemia as compared to the other insulins?
So yes,
human analogs.
Yeah, so hypoglycemia is one benefit which we are looking for, and definitely the data is there to prove the benefit in terms of hypoglycemia. And the weight gain overall is, I think, always secondary to hypoglycemia. So in most of studies, you will always say when the incidence of hypoglycemia is high, the weight gain is high. So we do expect that benefit also.
So Dr. Ahluwalia talked a little about insulin compensated cirrhosis and insulin in decompensated cirrhosis. Are they different? You probably would need less in the former and more in the later.
When you look at cirrhosis,
I'm sorry, it's just the opposite.
So insulin is metabolized by the kidney, not by the liver. The problem happens is when you have decompensated CLD, chronic liver disease, the hepatic glucogenesis comes down, the patient is, as it is, prone to both hypo and hyperglycemia. So there, the analogs are certainly beneficial because of the shorter duration of action, rapidity of onset of action, and decrease the risk of hypoglycemia. So you have to weigh options which are there. In patient with compensated cirrhosis, where the liver is producing enough glucose, it's basically again, in a hospital setting, you would rather prefer use analogs because of the shorter duration of action.
So Dr. Ahluwalia, tell us why would DP4 inhibitors not be used in patients who have cirrhosis?
See, DP4 inhibitors, you can, if they can be used in patients with cirrhosis. Linagliptin is a good combination where you have what is called cholestatic jaundice, or where you have, because it's going to be metabolized with the liver and excreted through the biliary tract. So it's a good drug to be used in patients with both chronic kidney disease as well as chronic renal disease. So you can then, linagliptin outscores the others because the dose reduction doesn't happen. So you can use them. Then secondly, because the glucose patterns are very erratic and you're likely to, a lot of drugs like sulfonylurea, metformin, you would not like to, those drugs which are metabolized by the liver, you would not like to use them. So in such case, basically DPP-4 inhibitor, especially linagliptin, if you're ruling out obstructive jaundice, and insulin, that is the one which you use in patients with CLE.
So the last question.
Last question, Dr. Chauhan says, and he's continuously looking at his wristwatch for me to finish. So, to both of you, see, not everybody, to both of them. So, would you say probably use drugs like GLP-1 agonists and probably twitcretins and retatrutide, which is a triple agonist, to be used in patients who have chronic liver disease as compared to the insulins today? We know retatrutide, the triple agonist, reduces fat, liver fat by 90% in 36 weeks. Tell us, sir.
Monjaro is still not available. These studies on chronic disorders and that's
what about GLP-1 agonists?
So even GLP-1 agonist or GLP-1 receptor agonist, you would be reserving them. You can use them in their studies to the effect of chronic kidney disease, but with chronic liver disease they are not. So you should not. The only drugs which are remaining in when you use with decompensated liver disease is insulins, and that also you have to reduce the dose depending upon the glucose profile.
Thank you, sir.
Dr. Kalra, sir, you exactly 2 minutes, sir.
Sir, I am reminding of solar eclipse. When sun eclipses the moon out here. So he has eclipsed me by 2 minutes, sir. I will not take more than 1.5 minutes. My 3 points, sir. First is, what is the highest level of HbA1c you have seen? HbA1c level, we have seen around 20.
So basically 19-20, that is the highest HbA1c.
And I came to know,
routinely 15 to 20 right at the onset of diabetes.
I came to know it was more than 61.5 in one case. It is reported. So I am just reminding of jalebi. How a jalebi can involve more concentrated glucose or say syrup. So it's one of food for thought.
Yeah, so we would have to that would be one of these off-case reports.
Sir, just मैं इसको लाइट करना चाहता था. डॉक्टर साहब ने पता नहीं क्या क्या खिला दिया हमें, तो मैं उसको जलेबी बना के जरा बताना चाह रहा था. Sir, there was a point in one of the slides, sir. It was fasting blood glucose divided by HbA1c, and Dr. Podar also had pointed to the same. I want PP blood glucose divided by blood HbA1c versus these two. Is there any study? Fasting versus PP divided by HbA1c. So, which is more important? I think both are important. Weekly the more important because we are more in the PP form.
Yes, sir.
14 hours in a day we are eating.
Yes.
Unless we are sleeping, we are eating.
Absolutely agree. So even in that equation, the fasting divided by HbA1c higher goes in the favor of actually the fasting. The basal insulin, the lower ratio goes in the favor of postprandial insulin, and that ratio is indirect calculation of average glucose values of the 1% HbA1c, which is 20 to 23. That is indirect ratio.
Let me save the time. Last comment is insulin in a normal person, insulin in insulin resistant person, they are different. Insulin resistant people, they have higher insulin levels, they have more atherogenic, inflammatory and all that. In a normal person, insulin is okay, it's a friend. But when it is insulin resistance, it's not a friend. It's just like opposition. It's a Mahayuti or whatever you can say.
Thank you. So there, the first choice will be sensitizers, not insulin. Absolutely agree, sir. Wonderful comments.
We had a wonderful session. Big hand for our moderator, wonderful speaker, and our silent moderator, Dr. Cmes. Yes, I would like the last comment from Dr. Cmes, sir.
Thank you, Sushi. It was a lovely talk and a very interactive session with a group of us. I must say that Dr. Ahluwalia is very well spoken. And role of premix insulin, basal insulin,
or there is monotherapy. It is very important, and we have done a lot today, and we should follow these instructions. Thank you very much, both of you.